Welcome back to the medical student channel. I'm Salah Abbas, and I'm a general surgeon with subspecialty in hepatobiliary and pancreatic surgery. Um, Today I'm going to talk to you about pheochromocytoma. Um, Pheochromocytoma is an interesting disease. It's a rare problem, but can be quite a pathological trouble that can lead to a lot of complications. Now, the first time that was recorded that a pheochromocytoma was removed was in 1926 by Charlie Mayer, successfully removed, and the patient survived. It has been described before that, but mostly in post-mortem series. It was called pheochromocytoma because if you add chromium salt to the tissues of a pheochromocytoma, the yellow to orange type of color changes into a brown color. So that's the base of the name. It arises from the adrenal medulla. It can also have extra adrenal origin from other sympathetic ganglia, particularly in the lumbar plexus or in the thoracic plexus. Now, why pheochromocytoma is a health issue? Because it secretes excessive adrenaline and noradrenaline, and as a result of that, it will have an impact on the patient's health with high blood pressure, cardiovascular complications, and cerebral complications in the form of strokes and cardiomyopathy, etc. Majority of these patients, when we find about them, they are in their 40s to their 50s. They are suspected, and that's when the suspicion arises, when there is a difficult to control hypertension, or when they describe their typical symptoms that we will see in a minute. Pheochromocytoma only accounts for 2 in 1,000 of all patients who have hypertension, and the majority of these patients, as I said, they are young, and without treatment, it does have a very high mortality, between 25 to 50%, usually from cardiac complications or from cerebral complications. Now we have to study the clinical presentation of the pheochromocytoma. I've got a picture for you here on the right side. It is the tumor being bisected, and on the periphery we can see the normal adrenal tissue attached to it. So it is again yellowish when you cut the tumor, and the center has got some brownish areas, plus areas of necrosis and hemorrhage inside. The typical patient would present with intermittent attacks of palpitation, anxiety, headaches, and sweating. Now, the hypertension or raised blood pressure could be continuous, but it could be episodic. And with these episodes, they get the dysrhythmias that lead to palpitation or sinus tachycardias. They have a fear of impending doom when they have good crisis of excessive secretion of adrenaline or adrenaline associated with bursting headache and generalized diaphoresis. However, the typical presentation is not there in all patients. It might happen in less than 50% of all patients with pheochromocytoma. In the past, when surgery and anesthesia were not very advanced, they used to call it a time bomb because of the hypertensive crisis that it can lead to, which can lead to severe cardiac damage and strokes. Eventually, in the long term, if the patient is not treated, they will suffer from cardiomyopathy and cardiac failure, and that can be diagnosed with an echocardiogram during the patient's treatment. Pheochromocytoma also have been dubbed the 10% tumor, and the reason for that is that on average, roughly there is 10% of the tumors are bilateral, 10% are malignant, 10% occur outside the adrenal gland, and 10% is familial. And the familial one happened to patients with von Recklinghausen disease or the neurofibromatosis, where you see neurofibromas in the skin in a lot of sites of the patient, and this patient can develop pheochromocytoma. Also, it has been described in von Hippel-Lindau disease, which is a rare vascular problem, and there is an inherited gene that deals with the succinate dehydrogenase gene, the enzyme succinate dehydrogenase. If someone inherits a faulty gene responsible for that enzyme, they are found also to have developed to have the ability to develop pheochromocytoma. As with any illnesses, the first thing we suspect the diagnosis, and then we have to prove it. And with the diagnosis of pheochromocytoma, we need to have a biochemical proof of the excessive catecholamine secretion in the system. And once we found that, then we move on to find where it was coming from, which could be either the, as I said, the adrenal or the sympathetic ganglia elsewhere in the body. The standard test that we request for the patients if we are suspecting a pheochromocytoma, I think we mentioned that with the management of incidentalomas, is the plasma metanephrine. The plasma metanephrine is very sensitive test. It's 99% sensitive. So the negative predictive value of this test is really great, which means that if the patient has normal plasma metanephrine, that it's very unlikely to have a pheochromocytoma. However, we struggle with the specificity of the tumor, which varies between 85 to 89%, which means that the test is not very accurate, and it will result in a significant number of patients having false positive diagnosis, which can be problematic. The next step is that we do 24-hour urinary catecholamines and their metabolites, which are the metanephrines, and this test has a sensitivity of 88%. If the test is positive, if we have excessive secretion of catecholamine and their amines and their metabolites, then we move to the next step, which is the imaging. If the test is negative, then we can do suppression tests, and these are usually in the form of clonidine suppression test. Small dose of clonidine, and clonidine is an alpha blocker centrally acting that will lead to reduction of the sympathetic output in the entire sympathetic ganglia of the body. So if it is not suppressed, then we move to the imaging. If we get suppression as a result of a small dose of clonidine, so it's clonidine and measuring the plasma metanephrines and the 24-hour urinary catecholamines to see if they are elevated or not. So if they are suppressed by the clonidine, then it's likely to be stress-related because excessive adrenaline and noradrenaline could be stress-related either to illness or emotional stress or physical stress or trauma. Now, if the test is shown no suppression of the secretion of the catecholamines, then we move to the next step. And the next step is going to be imaging. And as I mentioned in the past, the standard imaging that we do is a CT adrenal protocol. Also, if we are suspecting pheochromocytoma, it means that we need to do the chest, the abdomen, and the pelvis, a normal CT scan, portal venous phase, in addition to the adrenal protocol CT scan. Now, the role of MRI comes in place where the appearance of the lesion on the CT scan is not typical for a pheochromocytoma, or clinically we are not sure if the patient has actually excessive catecholamine secretion. Then we do MRI in the presence of an adrenal lesion. Then we do MRI, and it's the T2 phase of the MRI that gives us the diagnosis. Majority of pheochromocytomas will have a bright appearance on T2 phase of the MRI. So the presence of if the lesion is T2 hyperintense, then that's likely to be a pheochromocytoma. Because of the possibility of the tumor being bilateral and extraadrenal, then we might need to look outside the adrenal gland if we don't find a lesion on the CT scan and the MRI. Then we can do functional imaging, and the functional imaging are nuclear scans, and these are the gallium PET or the meta-iodobenzyl guanidine MIBG nuclear scan. They are specific to pheochromocytoma, and they will pick the lesion. Also, the importance of these two scans, the PET and the MIBG, they are useful in the follow-up of patients who have had resection of a pheochromocytoma in order to monitor them and observe them for the possibility of recurrence. Now, once that we diagnose pheochromocytoma, we know the only possible cure for them is removal of the offending adrenal gland. These patients tend to be quite unwell before the operation, so they need optimization. And we do that optimization in coordination with our endocrinologists. Because of the ongoing long-term vasoconstriction that caused by the increased muscular tone from the adrenal and noradrenaline in the peripheral circulation that affect mainly the capillaries and the venous capacitance, these patients tend to be hypovolemic. They are depleted with regard to the intravascular compartment. That's why we need to optimize them for a few weeks. So the first thing we do an echocardiogram in order to assess the left ventricular function, get an ECG to ensure they don't have certain arrhythmias. And then we move on to blocking the alpha receptors first. And we use an alpha blocker, which is known as phenoxybenzamine, and that is usually started as 10 milligram BD, and we can increase the dose gradually over a few days, usually 3 minimal, to control the high blood pressure. And the maximal dose that we could use is 40 milligram 3 times a day. There is another alternative, which is called prazosin. This can be used as well, and there are a few other alpha blockers, but phenoxybenzamine is the most commonly used and has been used for a long period of time. Once the patient is blocked, which will take a few days, then we can introduce beta blocker. And the reason to do that is some of the beta receptors can also be activated by adrenaline, and that can lead to high blood pressure. So if we block the alpha receptors, we need to have the beta receptors blocked in order to control the high blood pressure. In addition to that, often it is preferred that the patient stays in the hospital during this period of time and have intravenous fluid infusion to restore the intravascular compartment volume. And once their blood pressure is under control and their cardiac function is thought to be optimal, then we sign them in to have the operation. The operation is done usually laparoscopically, unless the lesion is very large, and the cutoff for the laparoscopic surgery is somewhere between 8 and 10 centimeters. They are difficult patients to deal intraoperatively, and the burden of the anesthetist is usually significant. So the anesthetist will put an arterial line, they will put a central venous line in addition to the peripheral lines, and these are to monitor the intravascular volume, also to monitor the arterial blood pressure, among other observations that they do routinely for anesthetized patients. You'll find that the anesthetist will prepare an infusion of alpha blockers or other form of vasodilator. And the other form of vasodilator that is commonly preferred by anesthetists is sodium nitroprusside, SNP. The reason for that is the SNP is short-acting, so it does not result in a prolonged period of hypotension following removal of the tumor. They will also have an infusion ready to go with the alpha stimulant, which is usually noradrenaline or methadone, because the blood pressure could plummet down to unrecordable once the tumor is removed, both as a result of removal of the driving force of the catecholamines from the tumor itself, and also as a result of the infusion of the vasodilators and the alpha blockers. These lesions tend to be usually vascular and intraoperatively, and they can bleed, particularly if they are large in size. If they are small in size, they are easier to deal with, and we often advise that we dissect the adrenal vein and ligate it or apply some form of metal clips or a plastic hemolux on it to allow the anesthetist to manage their blood pressure safely. There is a risk if the tumor is manipulated or there is excessive outpour of adrenaline and noradrenaline during the operation, that the patient could have ventricular tachycardia or cardiac arrest. And hence the difficulty of these patients during anesthesia. You will find that once the tumor is out, their blood pressure goes down, and then we will spend a bit of time to give their blood pressure into the normal level that's useful, that's optimal for oxygenation of vital organs. And that's usually done by intravenous fluid and vasoconstrictors. They get admitted to the intensive care unit usually that night for observation until we have got good grasp on their blood pressure control and their cardiac function. I have got this algorithm for you for the investigation of suspected pheochromocytoma, and that's the algorithm that we normally use. You could pause your video at this stage and have a look at it and see how we go about the steps of the diagnosis and management. Then there also I want to point out to you that some of the pheochromocytomas are malignant, and the problem with endocrine tumors to differentiate between benign and malignant tend to be hard on the part of the pathologist, and the only certain evidence to prove that the lesion is malignant is the occurrence of metastases in the long-term follow-up of the patient. But in general, pathologists look at the lesion and they put a score to the lesion. And the one they use for pheochromocytoma is called the PASA score, and it is dependent on nuclear hyperchromasia, nuclear pleomorphism, if there is vascular invasion, if there is capsular invasion, extension of the tumor into the adipose tissue in the perinephric region, atypical mitosis, high number of mitoses, more than 10 per 10 high power field, and the others are if you have spindle cells or not, and whether the cellular anatomy of it is monotonous or variable. Also the degree of cellularity and the presence of necrosis. So it's a large number but just to give you an idea, the most important things are capsular invasion, vascular invasion, large mitotic numbers, and profound nuclear pleomorphism, and also necrosis. So the pathologist will give that score and will tell us whether they think this is likely to behave in a malignant fashion or a benign fashion. Hence, we have to follow them up for a long period of time by measuring their blood pressure and checking their catecholamines. And if the catecholamines go up, then we scan them. And in the follow-up period, when we scan them, we do a conventional CT scan, chest, abdomen, and pelvis to start with, because if they metastasize, they will metastasize usually to the lung and to the bones. And if the CT scan largely shows no lesion, then we could proceed to do a nuclear medicine scan, usually in the form of gallium PET or the meta-iodobenzyl guanidine nuclear scan. Well, that's in a nutshell all we going to what we learned today about pheochromocytoma, and I have kept it to the minimal, and hopefully it has been useful for your learning. It would be great if you could leave us your comments in there, and let us know if you have any questions. And I will see you in the future. Thanks.